15th edition of Child Ready Web Talk. And we are doing this in preparation for EMS Week. So I want to thank all of our EMS providers across the state, across our great nation, just for everything that you do every single day. You guys are amazing providers and a gift to the rest of us that aren't active providers. And I just want to say thank you again for everything you do. This evening, we'll be talking about from Inexperienced to Jaded. So we have a group of panel members here that are some of my dearest and closest friends and somebody I've known his whole entire life. And we will go into that in just a second. But I want to welcome Scott Oglesby, who is a paramedic, and he can tell you all about himself in just a second. Tanner Schaefer, yes, similar last name, because that's my son. And Mr. Chad Kim, he is our EMS for Children Advisory Rep, and he'll give you some more details. In addition, my name is Catherine Schaefer, and I'm your New Mexico EMS for Children Program Manager. I really want to thank you guys for being here tonight. And I'm going to give one more shot as we go around the table to introductions. I'm going to try and log on and do this thing in Facebook. So let's start with Mr. Kim.
Hello, everybody. I'm Chad Kim. I'm a battalion chief with the Albuquerque Fire Department, and I serve a dual role as the EMS for Children Family Rep. That's all I got.
Hello, I'm Tanner Schaefer. I currently am a cadet at the Bernalillo County Fire Department. However, I do have some limited experience in the 911 setting, as I was an EMT intermediate down in Valencia County for about 7 months.
My name's Scott Oglesby. I have my MPH in epidemiology, and I'm a critical care paramedic as well. And I work here at UNM as a clinical research manager, overseeing some of our NIH projects and some research we've done in-house as well, which we'll start to talk about in a little bit.
All right.
So with those introductions, I am going to hand this presentation over to our esteemed panel members. I may chime in with some questions a little later.
Yeah, please do.
So I thank you guys for being here. We do appreciate that you took your time away from your families and this evening to join us. So with that, thank you. Let's start our program.
All right, let's go. So we have a couple of objectives here. I'll read maybe one or two, and then we can pass it off so that no one gets tired of just my voice. So first objective is to explore the importance of updating pre-hospital treatment protocols. The second is to explain pre-hospital treatment of apparent life-threatening events. Tanny, mind grabbing a couple?
The third one here we have is to provide rationale of brief, resolved, unexplained events guideline, and finally to describe difference between protocols and clinical practice guidelines.
All right, thank you. We're going to start this off with a pretty simple case study. I was involved in this call, and so I took all the ways to actually track this patient back down. I actually removed it all as I should. But I'm going to give you some really good hints of kind of a window into what I was experiencing during this. So this event happened just about a month ago, and the initial dispatch was at 21:34 hours, where I heard the vocals come over and they said, it is a 15-month-old in cardiac arrest. So Tanner, I kind of looked to you, and if you heard that call as a fairly new guy.
My blood's pumping.
And are you running to the truck? Are you hesitant? Are you...
I'm pretty excited at this point. Not excited like in a good way, but my blood's definitely pumping. My adrenaline's going because I know this sounds like a really critical call, so I'm getting going.
Good, as you should. I want to caution a lot of the viewers that it's oftentimes these are the type of calls where excuses come that I was emotionally driven because it was a kid. That is an excuse, but not a good excuse to behave poorly, drive well beyond the speed limit, etc. So we should actually kind of put ourselves in check sometimes. And I think that's maybe where the experienced provider says, it's okay not to do 100 miles an hour to the call, but you should get up and go fast. Scott, do you have an opinion on that?
I concur.
Yeah,
Yeah, right.
Have you yourself done that, Scott?
Well, I've done that a couple times. We hit 100 miles outside of Taos County, 100 miles per hour outside of Taos County. But with that in mind, the vehicles have safety limits. But more importantly, with pediatric patients, I think a lot of times they're not afforded the care that they deserve because people's adrenaline is pumping. So taking that deep breath and approaching the call rationally is of utmost importance. So don't forget your protocols or your guidelines in those type of situations. And be careful with the ambulance at 100 miles per hour.
Thank you. I think enough said there. So it's basically 9:30 at night, 15-month-old cardiac arrest comes in. The response for this particular call at my station was the closest engine rescue, which I shared that station with. Myself as a battalion chief, a quality assurance captain who comes alone in another Chevy Tahoe. In the Albuquerque metro area, we're blessed with physicians that come to our events, self-dispatched, but they are consortium doctors. In that case, we had one, and the closest ambulance. That's a lot of people, and I want to ask maybe some of you all, do you know how many people that is?
Oh, that's 10 or 11 people. That's a lot.
That's a
lot of people.
You ran in Taos.
Right. So we'd run these type of calls with maybe 1 or 2 providers tops. And probably as a EMT intermediate, you're the highest trained person on the ambulance.
That is. In this particular event, there were 11 of us coming. And sometimes I have to question, is that too much? Sometimes it's really nice to be able to err on and look up to the veterans and say, hey, kind of guide me. But if the veterans aren't there, the newer folks will figure it out, I think, in due time. And they're forced to. So sometimes too many providers could be bad because less people are afforded skills as well. All right, once I got there first. I'm not going to say that I drove fast. But somehow I got there. And upon my arrival at about 50 feet, I see from the doorway that there's an adult doing back blows or chest thrusts. I couldn't quite make this out. So that was pretty alarming. So Tanner, what are you thinking when the call came in as a cardiac arrest, but upon my arrival, it looks like they're doing back blows?
And I'm still thinking there's a pretty critical call here, just from an inexperienced point of view. Looking at this, I'm thinking an airway compromise, possibly, if he's doing back blows.
Okay. At this point, do you think that child needs to go to the hospital with a little bit of info that you have?
In my opinion, yes. Just at this point.
Yeah, and I'm just trying to kind of get you to start thinking down what is going to be the deciding factor here. So remember that when we actually cause trauma to the back of a kiddo like that, or we push on their chest, we're inflicting trauma to that kiddo, right? So have that in mind, please, as we kind of move forward in the scenario that this trauma was done before I ever even walked in the door. So upon my arrival, what I did notice, and what I was very thankful for, was that the child had good color. So when we say color, Scott, what does that mean to you?
So, I would describe what not having color looks like, the absence of pallor or cyanosis. You want to look for signs of good perfusion.
15-month-old. That's kind of hard to do, right? Because we can feel the pulse like that in an adult. And Tanner, do you remember where to grab a pulse in a kiddo? The brachial. Right on. Don't call me sir, my friend. All right, we're moving forward. This kiddo has one episode of emesis, and emesis, I think we all know, means the kiddo threw up. And when this kiddo threw up, I had now taken possession of the kiddo and was holding the child as if it were my own. And there's now what I think is a Twix bar. So it was an odd kind of, So any discussion on why this kiddo might have thrown up? Because there's a lot of things going through my mind, but I'm curious if they're similar as to you all. Why would a child of 15 months old who just got back blows, who maybe was in cardiac arrest, why would a kiddo be throwing up on us?
So yeah, I would say that's probably something inflicted by the parent with the abdominal thrusts, chest thrusts, the trauma itself.
Yeah,
so
and thank you. Yeah. One of the things going through my mind was, is this a poisoning? So was it not necessarily a cardiac arrest? Was this somehow a kiddo had ingested some sort of poison, and the body's natural reaction is to upchuck it, if you will? I thought it was a Twix bar. The pulse ox is placed. So pulse ox, remember, most of our trucks carry equipment that you can just slide an adult probe on. Well, a pediatric probe was placed on the kiddo's toe, and that was awesome. I really appreciated that. The bummer is that it was not reading. So Tanner, I go to you. If it's not reading, is that a decision point to say, we need to go right now?
I don't think so. As you stated earlier, it wasn't a cardiac arrest. The child was in your arms. Airway was cleared from what you're telling me. But I would like to do a more thorough assessment. And if we have plenty of providers on scene, then they can also stick their opinions in there.
Awesome. Good. So you rely on others.
Yes, sir.
Good. All right. Part of the thing that was really concerning me was drooling. Now, I remember going through paramedic school, and I don't remember learning a lot about drooling other than epiglottitis, but I was not suspecting epiglottitis in this case. But I saw the drooling out of both sides, and it was a clear fluid, so that was alarming to me. 3 more episodes of emesis. Now, this was starting to get old because I had now a shirt full of Twix candy bars. And I was very, very concerned as to why this child was producing so much emesis. And it wasn't like the first emesis looked any different from the last. They were all very similar in nature. So it was a lot of volume. And I wondered now, had the kid actually eaten too much? I did listen to the upper airway, and I heard no stridor. When I hear stridor, what should that be indicative of, Tanner? You remember?
The upper airway.
Yeah. And I didn't hear any of that. I heard no wheezing, but I suspected aspiration. So I suspected that maybe this kiddo was eating Twix bars, maybe got too full, started to throw it up, and then went, and maybe that's why the kiddo went unresponsive. So as you can see, some of my differential diagnosis is aspiration, poisoning, cardiac arrest, the list goes on. That's a lot of things to process in the first few minutes of an event. The decision was made to transport. I think that we can all agree. Good. And where should we take these kiddos? We are blessed in the metro area we have a pediatric facility that specializes in such things. We also have other hospitals that can take pediatric children. Many services in rural New Mexico and around our country don't. So to answer that question, where do we take the kiddo? Do we answer closest hospital?
UNM. I always recommend my pediatric patients for UNM.
Okay. But in rural New Mexico or rural United States, closest hospital? Yeah, I think we should say closest. All right, around to the hospital. The crew doesn't want the mother to ride. Any thoughts on that? This mom was crying.
Yeah, that sounds like a slippery slope because a lot of times the parents might be emotional and hyper-reactive to the situation, but that's not necessarily a bad thing. It might be a normal response, and you have a caring parent who legitimately cares about their kiddo. So I err on the side of letting the parents transport in, regardless of their emotional state.
Can I give a mom's perspective?
Please, Captain.
I want to be on that ambulance with my child, and I get it. I'm emotional. I'm out of, I might be a little bit above my normal self, but I don't want to be more than 2 feet away from my child during that critical transport. So you better find a way to remove me with a physical because I'm going with you.
I just thought of something else that we're very hesitant to take the crying parent. What if this parent was unemotional? Would we maybe start suspecting something from the parent? And would we then go, maybe we want her to go because we want her to talk to the cops? Would we maybe think like that? And I don't know that answer. Thoughts?
I think you make a good point right there. It's a fine line between finding out, what type of parenting people do, but I don't know if we necessarily have the right to judge based on one experience.
Good job. But can we maybe agree that it should raise an eyebrow? It's one end of the extreme to the other. Maybe we could at least just take note and add that to our slide carousel so that we say, the next time we have this kind of call, we go, well, the last one was, and that's how we gain experience.
And also to point out in these situations that aren't exactly clear cut, and there is a child who is in a severe, severe condition, you may start thinking that there could be child abuse related to this, and something more. Touch on a little bit later.
Thank you. All right, so the SAT's 90%. That's low. Even at this altitude, that is a low for a kiddo. So I wanted to kind of touch on what are some of the reasons that SAT could be low. A, kiddo was a little cool to the touch. B, maybe it was me because I was holding this kiddo like this. I was wondering in hindsight, could I have been accidentally, constricting that lower extremity, causing a bad reading? I don't know. SAT of 90 actually, I should ask you, are you okay with that?
I would apply some oxygen.
And I think that's where maybe I can kind of lead in with experience versus inexperienced. I'm kind of looking at that 90 going, I'm not going to take action yet. I'm just going to kind of look at that. So thanks for sharing that you might apply oxygen. That's certainly not bad, but there were other priorities that I wanted to get done. But awesome. I like the way you're thinking. Patient, in my opinion, was stable. The father goes to retrieve the car seat. I just wanted you all to picture this father that thought that his son was in cardiac arrest 5 minutes ago, and we just tasked him with going out and getting a car seat. Just put that in your little cap back there, and we're going to talk about it later. In the long run, the ambulance came with the car seat, and thank goodness we used it for transport. And real quickly, let's touch on, should we ever transport children out of car seats? And I hate to say no and never, but should we ever transport a child outside of a car seat or a restraint?
Well, that happens to be my favorite area, and the one I'm focusing on. So as part of the National Association for EMS Officials, we did provide a guidance on safe transport of children. And the best practice is, no, you shouldn't ever. But having been around New Mexico enough and understanding what our providers are faced, we do understand that you may be in a circumstance where you've got to do what you can do at the time. But what I'm going to ask is that the services be thinking about what they have on their vehicles ahead of time before this, like you do every other piece of equipment that you put on and take on and off that ambulance. Keep that passive child safety seat as one of those things that you practice using, so that in that situation you know where it's at, you know how to put it on the gurney correctly, and you know how to harness that child in. So it should be one of those pieces of equipment that you practice on, just like everything else.
That's a great point, Catherine.
Do the best you can with what you have, but
utilize parents' car seats, or maybe their own car seat is maybe a better way to word it. Find a way to get a car seat that will fit a wide variety of kiddos. Find a place to put that in the ambulance. Ambulances also, you can spec them to have a car seat built in. So there are many options to deal with this before, I think is what you're saying, the emergency, rather than as it's happening. Fair enough. The mother does ride in the ambulance, and just in case you're wondering, she rides in the front seat. So she was under a seatbelt and in no distress as far as screaming and yelling, and in my opinion, wasn't going to be doing any of that. Upon arrival at the hospital, I opened the back doors and no airway equipment was ready during transport. We're going to kind of come back to that. Instead, what was done was some blow-by oxygen, and that didn't really touch the set other than maybe 1%. The initial MD and the MD believed that this could be epiglottitis or infectious croup. I did not hand over the initial patient care report. One of the other providers did, but somehow in translation, because of this doctor's experience, which they are much more experienced than I could ever be, this doctor believed epiglottitis or croup. So with that type of diagnosis, in comes the NEBS. And a chest x-ray is done because I'm suspecting by now a foreign body. Because of my little slideshow that I showed you earlier, drooling to me in that age group, I was very, very concerned with an upper airway obstruction. But the chest x-ray didn't show it. So I was somewhat defeated and going, wow, I really failed this kid. I was going down a treatment path. Not that I would have stuck McGills in the kiddo. For those of you that don't know what McGills are, pliers, for lack of a better word. Pliers going down the airway to try and find a piece of whatever it could be, foreign body. I felt like I had let the kiddo down because nothing was found on an x-ray. Scott, do you have any opinions on that? Would you have done anything differently or advised any differently?
Interesting. Well, we have our pre-hospital management of this situation, and it sounds like the providers touched on most of the bases that they needed to. They could have been a little more prepared with the airway. Now, in a hospital, it's a different situation, and x-rays are typically considered definitive.
Yes.
One of the questions I have after displaying the image that I think is going to pop up in a slide or two, was it anterior, posterior? Did they do a lateral view? Sometimes you have confirmation bias that the providers might have been seeing what they want to see, considering it might have been epiglottitis, and not seeing what they don't want to see, the fact that there could still be some foreign body airway obstruction.
Tanner?
I have a question if we have time here. Thinking about what you said a little bit, How did you tell the difference between the drooling as a possible airway obstruction to a baby who's just drooling? I know my son drooled
Like
a
teething.
lot. Right.
Yeah, I can only tell you I have 3 sons, and none of them presented like this. So again, it's that slideshow that you're building, and you have a child yourself. So you have now a little bit of experience through one child to see what teething drooling looks like versus an airway obstruction. And I think that's one of the difficult concepts here, Tanner, is I'm trying to give you or just discuss 20 years of being a paramedic. I'm trying to show you that and give you that. And I'm trying to say it looks like the others when that's impossible for me to do. It's impossible for us to teach you that. And so I think if we can break down a barrier and figure out how to teach that skill set, Scott, I don't know. That's difficult.
I think it's more conversations like this.
All right, now what? So I felt defeated. I left the ED, but I did talk to the charge nurse and one of the nurses in the ED and said, somebody's got to believe me. I think I'm right. Actually, I didn't say I think. I said, I know I'm right. I've seen this before. I actually had a death of an adult patient with this exact scenario. This is a scan of the kiddo, obviously from the side, and nothing was found. And imagine that I kind of put all this emotion into an upper airway obstruction, and nothing was found upon x-ray. And I was almost validated by the other folks on the scene saying, see, Chad, it was nothing. 2 hours later, though, the child was taken to the operating room and 2 pieces of plastic were removed from below the cords. Oh my.
Wow.
So, why is that? Why didn't that get caught on x-ray? Any thoughts?
I've seen the next slide, so I know the answers. Sorry.
Yeah. All right, let's give it up. The kiddo was discharged the next day. Oh, I'm confused. I must have missed the last one there. Plastic is not radio opaque, meaning it cannot be seen upon x-ray. And that's why it wasn't ever noticed. So what I'm not telling you there, though, is that time delay from when the patient was discharged or sitting in the ED initially upon arrival to when 2 hours later when the kiddo went to the OR, there were nebs given. The patient was held down physically to try and introduce more oxygen. And I want to just kind of say this to you, Tanner. You're running in the academy. If you run 5 miles and then somebody holds you down as you're short of breath, what does that make you feel like?
Claustrophobic.
Absolutely, and hard to breathe. So we should be cautious of holding anybody down and giving them a breathing treatment. I mean, it's just a little archaic, but maybe there's an example of where you would do it. So the lessons learned for me, and I'm going to wrap this up. This is good timing, everybody. Child seat. I think let's echo what Catherine said, that let's do more preparation in the beforehand. Before we ever got to this point, we did, and the ambulance did, in fact, come prepared with a car seat, so kudos to them. Should we have used the services car seat first or the parents? Remember I told you that the dad, 5 minutes before, thought that his child had just died. So we sent poor dad out to the car to get a car seat, and you can imagine, if you've mounted a car seat, what that's like, trying to get that thing out of the car, and poor guy. I thought in hindsight, we could have done better. We could have performed better and said, let's use our own car seat. I have a deep down belief that family members can and should ride to the hospital. Even if they don't ride in that ambulance, I will give them a ride in my battalion chief's truck, because that parent needs to go with that kiddo. As a parent, I echo Catherine's words there and say, I'm going. Airway equipment should always be prepared. The one example that I was citing this whole event to, which was an adult airway that went south, and we wound up cracking him, had a failed airway, and he passed away secondary to this. So not having your equipment out and on the bench ready to go is crucial for me. And I'm curious, if you had this call today, or actually last night, would you have gotten your equipment and set it on the bench, or would you have maybe just put your bag beside you and been ready?
Option number 2, I would have just put my bag there. I mean, we already have it fairly close to us, and we had it in our ambulances fairly close to us. But I can't recall a call where we had everything out on the bench ready to go, to be honest.
Well, and something to consider with these
Yeah.
pediatric cases, you said the Ross locate for an appropriate
Oh, well.
weight-based measurement system. So you can pre-plan if you do need to intubate, what size ET tube we're going to be using, what size laryngoscope blade, et cetera, et cetera.
Thank
So, I know grabbing the airway kit sounds like a nice and easy solution, but, once you get in there, then it's a whole realm of itself. So,
And emotions are going to be going high there.
yeah, and that's something in critical care. I think it's almost second nature when you do have a lot of potentially unstable airway patients.
Skills practice. I mean, knowing what's in your truck and how to use it. I think I go back to that.
Yeah.
Knowing where that bras go at and what's going to be on that tape, or, what you're going to look at when you're.
Well, and you save your partner a bunch of cleanup. You start pulling everything out of the airway bag, and it takes an hour to clean up afterwards.
And actually,
It's
one
preventative.
point of topic here is that we all think back in time, because this is not just for New Mexico. This is across our world, potentially. Pediatric airway was taken out of our paramedic scope of practice here in New Mexico because of failed unrecognized, that's a big word I want to say, unrecognized esophageal intubations. So in this case, we still have the blades and we still have McGill's, but we have no tubes to actually fill that void other than a 2.5, which is usually used for meconium aspiration.
Right. So if you were going down that pathway of airway obstruction, you could potentially visualize and remove the said pieces of plastic with the McGills. But that would have been, you would have had several more indicators than just drooling and some instability.
Oh, there's my slide. Plastic is not radiopaque. I think that this is really where I wanted to kind of end this small case study, in that it's okay to be an advocate, and sometimes we're wrong. In this case, I got lucky and was right, but it's sometimes hard to be that advocate because sometimes we don't want to stick our necks out. We want to be quiet. We don't want to say something because what if we're wrong? So the advice I give you, my friend, is speak up. Speak up, because you don't want a bad outcome on your shoulders over time, and that's really a hard one to have. And I'm sure, Scott, out of your 20-year plus career, you have some of those bad outcomes that you maybe should have said something.
Oh, absolutely, and I think that's why we chose this topic of the topic heading of Jaded to Inexperienced. The fact that somewhere there's a happy medium where you're not omniscient and you know exactly what every call is, but you might approach it a little bit differently in your experience. With that said, I think our junior personnel and people who just got out of fire academy and just got out of VMT school, they might be a little more on top of the current treatment guidelines than the more experienced provider might be. So
we're going to move from that case study to, this is kind of the guiding light for me, myself, and I, the apparent life-threatening emergency or event that Tanner actually and I operate under in Bernalillo County. So this is a protocol that, even though this is a dated slide, if you will, this is the actual protocol to the right, M7, has not changed. It's the slide on the left that actually periodically gets updated, as many as twice a year. So the points I want to capture from this are 1, 2, 3, and 4 at the top. So if we respond to a pediatric, not necessarily age dependent, but a pediatric that has had, according to the caregiver, apnea, a skin color change, a marked change in muscle tone, unexplained choking or gagging, we should elevate this kiddo with our index of suspicion to say something is wrong. And another point that I wanted to capitalize here on is right above all providers, that big bold line. It says the majority of infants with an ALT will appear to be in no acute distress when evaluated by EMS personnel. So I just want to transplant us into that event. We respond 2 a.m. Caregiver says, my kid went limp when I was breastfeeding. And you get there and kiddo's jumping around, acting completely normal. And it's 2 a.m. You're a little fatigued after you've been up all night, and you go, but kiddo looks fine now. So sometimes it's a barrier for us to say, kid's fine. The last thing that we should say is that exact phrase is, your kiddo is fine. If you remember those 4 bullet points up there, that should raise our index of suspicion and say, because the next sentence it says, therefore, the signs and symptoms noted by the caregiver should be considered credible, even when they do not match the observations of EMS providers. So again, I want to say it that if upon our arrival, kid is basically acting fine, but they've had allegedly one of the 4 high index of suspicion. So I've been talking a lot. Scott, you mind just reading off one of those bullets there at the top?
Oh, yeah, absolutely. So oftentimes the parents and caregivers might believe that the infant suddenly and unexpectedly died. So this type of presentation is consistent with your earlier case scenario, Chad, because of the fact that the child was initially unstable, possibly, given the fact that, granted the fact that what the parents said were true, the child stabilized, and then you as a provider, you're there, and CPR might have been administered, 911 was activated, and the event resolved itself within a matter of minutes. So you really need to give the parent that credibility of what they experienced.
I think in this case, I didn't doubt because I still had signs and symptoms of something's wrong.
Right. Yeah. Absolutely. And I think that scenario would really fall well under ULTI because of the fact that the providers couldn't necessarily ascribe it to one type of presentation. You know, there could have been multiple scenarios going on. Just wasn't that clear cut. And so as you mentioned, the ULTI often is associated with apnea, difficulty breathing, lack of muscle tone, limpness, choking, gagging, color changes such as cyanosis or pallor. And it was first described in a consensus statement in pediatrics back in '87. Now, at the time, these physicians were really trying to differentiate ULTI from SIDS or a near SIDS-ness. And I don't know, Chad, you're probably old enough, and Kathy as well, but certainly not Tanner, I know what year you graduated paramedic school. No, to remember the cases of SIDS in all seriousness back in the 80s. It was a really rampant problem for a while and gained a lot of attention in the media. And so one reason I suspect that oftentimes these cases might be overtreated in the hospital is doctors are trying to fight that misperception that ULTI may be related to SIDS, which we know following research it's not.
Oof. So, Scott, you're going to have to walk us through this one.
Some of the common etiologies. So when you see ULTI, you know, you're not just thinking this is a pathophys in and of itself, right? So there's actually root causes that might have led to this one event. So 33% of these cases may be GI related, 15% neurological, 11% respiratory, think pertussis, or another type of respiratory upper airway infection. Ear, nose, and throat, 4%, cardiovascular, 1%, and child abuse. If you notice, that's one of the top 6 causes on the list.
Where did this data arrive from?
So in the references section, there's a paper that was released, I believe, in '97 on this topic. So they had done a review of all of these ULTI cases for a period of, I think, in 2 years, out of a couple different hospitals. So it was a pretty large study.
And it looks like the bulk of them gastrointestinal. That's pretty obvious. All right. Low risk of serious disease or additional event. Let's see. The mean length of a hospital stay. Wow. So when we're transporting these kiddos, is this data derived from the same slide as earlier?
Yes.
Wow. So this is 1997 data at that hospital. So the mean hospital charge of $15,000 was from 1997?
You know what? I might have misspoke. I think this is a second reference,
Okay.
and we can double check that later. But yes, point well taken that these mean charges would actually be higher due to inflation.
They
nowadays,
should be.
Right?
Yeah, they
Absolutely.
should be. So let me kind of digest this slide real quick. So if I have a kiddo that may be presented as potentially muscle tone went limp, breastfeeding, that exact scenario, breastfeeding, and then kiddo goes limp, mom, dad, caregiver calls us, we get there, kid acts fine, but we say, whoa, I got a protocol, this kiddo met one of the 4, we're taking this kiddo to the hospital, and right, I'm going to take vital signs, maybe a ChemVG, and this kiddo could potentially stay 4.5 days for going limp.
And I've got a question for you, Chad. So would you do that blood glucose level on a kid who's presenting alert and oriented?
No.
And okay.
No, but In my earlier days, I'm probably did. Tanner?
Guilty.
Ooh.
And absolutely, I was guilty too, and I used to treat these cases probably a little more aggressively than I should have. Even though the kid was alert and oriented, sorry, you're going to get a heel stick. We got to check your blood glucose level. However, with the data that's coming out now, that is not necessary if the child is alert and oriented.
Actually supporting not taking another vital sign.
Exactly. So less invasive is better, provided the patient is stable.
Well, I think though that's a word that most of us, I think, struggle with is what exactly is stable? Your definition of and your comfort level, Catherine's comfort level. I have 3 children versus he has 1. My comfort level might be high. I may believe that this kiddo is more stable than Tanner. So how do we really define stable? And I don't know if this is the venue for that, but it's certainly a discussion point for later.
No, that's a great point. I think we can touch on that with the protocols versus guidelines towards the end of the lecture.
That's great.
This, Scott, is what we brought you here to help discuss because as of about 3 months ago, I was pretty ignorant of this topic. I had relied on my own protocols and my own narrow-mindedness to keep moving forward, but I was fairly ignorant of this topic. So please enlighten us about this.
And you're an experienced provider, and so it was no shock that you knew about ALTI ahead of time. However, Tanner, you were aware of this type of condition, and you said you learned about that in your intermediate program,
school, yes.
Which is great because I know a lot of experienced providers who might not know about ALTI, and much less we're redefining the term with brief, resolved, unexplained events. So this might be somewhat of a leap. But with that said, this clinical practice guideline, or CPG, has been out for about 2 years now, and the pediatricians really want to get away from using ALTI and start using BRU instead. And part of those reasons are the fact, like we discussed earlier, this condition might be overtreated and overadmitted, resulting in unnecessary costs and pain and suffering for the child. Additionally, before this, there wasn't a really clear-cut guideline on who fits the ALTI protocol. There was a non-specific age range. Now that's been clearly defined. Yeah, so within 60 days to less than 365 days. In some of the database analysis that I've done, we had patients being diagnosed with ALTI up to 12 years old, which that might have been an anomaly, but there were certainly a large number of 3, 4, 5-year-olds with this condition who really there's a different pathophys going on. So additionally, there's high risk, low risk events associated with BRU. The duration is less than a minute. And one consistency throughout the protocols are the fact that there's one or more of these symptoms listed below. Something from the clinical practice guidelines, if you're still familiarizing yourself with guidelines and their usage, in the bottom right corner, there's a little key to how to read these basic flowchart symbols, kind of food for thought later on in your experiences. But what we take from this guideline is that providers, EMS providers, may be obtaining 12-lead EKGs. We can't necessarily test for pertussis in the back of the ambulance, but 12 leads are something we can interpret into our standard of care.
On a 1-year-old.
Absolutely. And you notice that what percentage were cardiac related? I think about 1%.
I know it wasn't 33. That's what jumped out at me.
Right. We could jump back and touch on that. However, in addition to that, we should also be discussing shared decision-making with parents and also offering resources for CPR training to the caregiver. Now, that might be something in New Mexico or individual services that they might not offer those resources currently, but it's something certainly within our purview that we could be providing.
Well, when I say the 12 lead on that 1-year-old, Scott, I don't think that my adult patches would fit on that kiddo.
Oh, interesting.
So I don't even stock those electrode patches that would fit. So
interesting.
I think that kind of, again, goes back to Catherine, just this little discussion. I just recognized that, wow, I should probably at least invest in those.
Right. Having the pediatric sized 12
And then doing
pounds.
what with that 12 lead is my question.
Well, so we'd be interpreting it for any type of, I mean, it could be a tetralogy, it could be there could be some conduction delays. So, interpreting the 12 lead like you would any other, not necessarily suspecting MI versus not MI, but more, are there any conduction pathway abnormalities?
And that kind of goes back into our local system, Scott, that if we obtain that 12 lead, I couldn't necessarily transmit that 12 lead because that would raise a lot of flags in the local system. This looks like a very normal 12 lead, a sinus TAC to the provider that's interpreting it. So that would take some legwork in the background to have discussions of when we transmit a 12 lead saying the age is 1, there's a reason behind it. So discussion prior.
And I'm so glad we're having this discussion, and I really think it touches on evolving medicine as we move along. Real briefly, I wanted to mention the differences in clinical practice guidelines versus protocols. As you start to evolve in your care, I think more providers start to operate under the guideline type assumption rather than protocols, where if you see this, then you must do that. Is one necessarily better than other? That's debatable, but we know that protocols are typically more detail oriented than guidelines. Guidelines are usually based on more current evidence. CPGs, they also tend to reduce variation nationally in standard of care. It gives providers some options to choose from. Finally, to contrast with protocols, they usually address management with specific steps, and there's high national variation. For example, protocols in Houston might be different from those in Albuquerque, but among our EMS system itself, there's going to be small variation internally. So there's some pros and cons, and I should point out that both typically include evidence-based medicine and consensus-based approaches. However, CPGs do tend to be a little more updated.
Ooh, that slide just caught me, Scott.
Yeah, I thought it would.
Okay. Hold on. I want to just digest this one.
And while you guys are doing that, I just need to make you aware we're at the quarter till mark, and we do want to allow some time at the end for questions. So digest, think about our next steps. We'll move forward.
Give me an idea of how many questions we have stacked up, Catherine?
So we don't have any questions at this time.
Okay. So if they start to populate, would you kind of give us a warning? Because we want to take advantage of the time, but maybe not quit if we don't need to. Okay, cool. Scott, I just got to point out the 1, 2, 3, 4, 5, 4 and 5. So are you telling me that if somebody smokes or there's alcohol use in the home, I'm supposed to say there's abuse or something going on here?
That's a great question. That's a
What
great question.
is this?
I love it. No, by no means. I think that would be jumping to conclusions. We need more specific signs of child abuse. But what you get as a provider, and it's something I know all of us in this room know very well, is you have a unique insight into these child's lives. If the parents do smoke, it could put the child at higher risk for respiratory diseases, respiratory infections. If there is alcohol abuse in the home, there could be neglect. So it's something that
but not always.
Could be, but not always. Yeah. So it's something.
Plenty of loving parents drink alcohol. Now, I'm not saying to drink alcohol while caring for your kiddos, but so I think that we should be cautious in stereotyping. I do get the flavor here that you're saying. Allow it to increase your sense of what's the right word there? A higher index of suspicion that maybe something's odd here.
Absolutely. And try not to get so tunnel vision into the patient that you lose sight of the situation itself.
Tanner, are you familiar with the triangle on the right?
Yeah, that's what we learned that in class still.
I believe that's taught in not PALS. PEP. The PEP triangle. So when you look at that, I think that if I could actually ask everybody to take away from that slide, it's if you can't remember anything, and one of my favorite phrases is at 2 a.m, if you can't remember anything at 2 a.m, if you could remember that triangle, that would give you a very good indicator of how that kid's doing. That subjective kind of, I can't remember what the heart rate's supposed to be. I can't remember what the Glasgow is supposed to be. But if you looked at that and went, is their circulation okay? Is their appearance okay? Is their work of breathing okay? If it's not, you should be starting to get worried, I think is the message that I'd like to send to maybe the more inexperienced provider. Cool. Thanks, Scott.
Absolutely. And just briefly to touch on the secondary exam and your interaction with the parents, consider the 12 lead EKG if your equipment facilitates. Continuous pulse oximetry is probably a good idea as well, provided that you're getting good feedback from your monitor. And really reassuring parents is key in this situation, letting the parents know their child is okay right now, reassuring that what they did or might not have done was okay, and the fact that you really validate their experience. I think that's huge, and you really touched on that well at the beginning of this presentation.
Think outside the box. Look at that. That's a hard thing to teach. And I think that I would like to add just a few more bullets to that is we spoke of maybe ways to be better prepared for all of these, from the case study to the alt to the brew, that having a car seat available. I recognize that in my own service, I don't have pediatric electrodes. And then pediatric O2 sat probes, many services, the cost drives a lot of this, and maybe, I'm not saying carry 50, but maybe carry two. Maybe approach that with your EMS distributor that sells you these goods to say, hey, I don't want to buy a whole box. Can I just buy two? And I would bet you'll score there. So let's see. The last one is inexperienced to jaded provider experience may be the best approach. Yeah. So I just have a question, Scott. So who was the jaded provider?
That's a really good question, and I would venture to say none of us are.
Okay, I like to see that. Okay.
Yeah, jaded might be a loaded term here. But,
all right.
All right. It's getting at what we want to discuss. Seeing the pre-hospital protocols evolve over time, I think, is really critical to staying on the cutting edge of care. And this is a protocol that I need to point out that the American Academy of Pediatrics has not released a pre-hospital version of yet. I'm hoping they do in time. So, with the caveat that you're always following your local protocols and what your medical director expects is crucial here. But also, I think as practitioners, and that's how I consider EMS providers to be, I think that sometimes we do have a unique perspective, and I think it does deserve the discussion of how best to manage in this situation, rather than a cookie cutter recipe. And I think that's what that gets at.
So I just to have so I did some training. I'm an EMT basic by training. I did not keep up with my certification.
About that. Yeah.
But I would have really, in those early years when I was working with Medbo and learning the practice, those protocols would have been my absolute thing that I would have gone straight to. But even in just being on the outskirts of this field now and watching you guys as providers grow, or my son grow, I think that you evolve to that guideline area. So I think as the basics and intermediates who are new in the field, those protocols are what they just need to know. You just need to have something to fall back on. But you guys have learned these. You take it in your slide set, you take it in your experiences, and you create that evolution to the guideline approach. So you guys are evolving. I see this in you presently. I see that in the years that I've known you, how you've evolved from that protocol base to a guideline base. And I really think it's an absolute joy to sit here and watch that, because I think as our providers across the state, I see that we have two extremes. We have some of our been there for decades, and then our new ones. That's what we have now out in the field. We have some very, very few of those that are in the middle. So it's really important that we remember that when you're on scene with the younger people coming in, that you give these learning moments to them.
Yeah, I have another point, thank you, Catherine, that I wanted to say, and that is protocols are very important to a lot of providers, especially those that write them. They
Right.
put a lot of effort. They put a lot of time. Physicians put a lot of time. And then they kind of roll them out periodically. And I know I work in a very busy system, and oftentimes our providers, they get a new set of protocols, and they're, for lack of better words, we all can become lazy. So a best practice for me is in my morning email that I send out to my troops, I give them one protocol per shift that we review when I visit with them. So perhaps that's a good best practice that some of you all can share in your services, is forcing the crews to review one. It helps that I'm passionate with EMS, but no boss ever did that with me. It was just expected that we would review protocols. So maybe you could take that with you.
Implementing best practice guidelines too, though. I think that's important as you are rolling out these protocols, understanding the research behind them, why they evolved to that protocol.
Yeah, sometimes it's hard to get that information. What
we need
led
more
us to this?
spots?
Yeah,
We need more
what
spots.
led us to this point? And maybe not everybody wants all those details, those fractions, those percentages, but knowing, I find that a lot of people are into case studies, and they tend to learn from that, and they say, we rewrote this protocol because of these bad outcomes. In a different way, Scott, you look at more data, which is, again, outcomes, potentially to describe a protocol change.
Right. And yeah, in the epidemiologic strength of evidence area, you go from case study to case control study to prospective cohort study to randomized double-blind controlled study, kind of like the medications, pharmaceuticals that we're available with. They've been rigorously studied. Something like this with Brew, it's actually at the case control study level, where we do have some evidence that we can be fairly reasonably sure that this type of case, and I absolutely agree with your pre-hospital management of this child. Like, it's such a great example that that you brought up today, because there wasn't a clear-cut explanation for the distress. Why was the parent providing back blows or almost CPR? And it really is just a diagnosis of exclusion. But anyway, back to the strength of evidence that support this, these guidelines. It's still in its infantile stages, if you will.
Do you think that the age, though, Scott, will increase from the 1-year-old? That is one thing that stuck out to me, is it's 1-year-old.
And that's a great question. I'll need to follow up with you a little bit more, but there's a low risk guideline, so lower risk guideline, where we're fairly certain that these children won't have a reoccurring event, and it's not something that has a severe pathophys where we really need to go in and test and keep these children overnight for admissions and run EEGs and do a spinal tap, for example. But I think the way the guideline is going is really that 1-year cutoff in less than 1 year, where you're going to have higher risk brews that might be less than 60 days. However, as the research evolves, we'll just have to see what happens to that 1-year age group to, I don't know what a reasonable cutoff would be. What do you think? Where do you think the upper cutoff age for?
Having done that case study to at least 15, it was a 15-month-old.
Okay.
I'm just thinking 2 years,
Interesting.
maybe 3.
We have some questions here. I'm so sorry. I hate to interrupt your conversation, but we have 5 minutes left, so let me see these. They popped up. So it says, at the start of the presentation, it was noted that EMS protocols should be reviewed and changed periodically. How often should these protocols be changed? What if our rural and EMS service providers do not have full-time medical oversight to evaluate, review, and change protocols, as is available in urban EMS service providers?
I can capture that one. So in the case of rural EMS providers, if they're in the state of New Mexico, so I can attest to this, that they can fall under the New Mexico EMS protocols, and that's a link through the EMS Bureau. And so your medical director could simply adopt those, change, delete, add to those. I hope that I was able to answer that question. Do you have a way to get feedback of whether the question was answered?
It was anonymous, but if anonymous could please type in whether or not that question was answered, or if you'd like more information, we'd really appreciate it.
And I think, I think that's a great question. Those protocols were last revised in 2007, and they do reflect current evidence at the time. And there's a hyperlink, number 5, that lists the Albuquerque-Bernalillo County EMS guidelines from which we had taken that M7 ALTI protocol.
And you'll see that that is the correct date, February 26, 2018. That is the most recent Bernalillo County protocols that exist.
And let's go to another question. On the brew versus ALTI slide, it said less than 60 days. What is it when less than, or yeah, greater than 60 days? Did I read that wrong? I read it wrong. Greater than 60 days. What is it when it's less than 60 days?
Right, that's a really great question, very intuitive. So when we start to get to that lower age range of less than 60 days, it falls into the higher risk category. And the American Academy of Pediatrics are releasing a guideline for that age group, and I believe it's actually under manuscript review right now. And I want to point out real quickly that, let me know if I'm wrong, but our medical director for Child Ready, Dr. Robert Sapien, was one of the co-authors of the BREW guidelines.
He did initiate this.
I did, yeah. Did I mention that? So he is responsible for, in part, for the lower risk guidelines. And like I said, there'll be a high risk guidelines that are coming out soon. And treatment of those children could be different. So
thank you.
Thank you. And then there's one more question. What type of car seat should the rural EMS providers consider as part of the equipment they might want to include in their ambulances? And may I?
I would hope so, Catherine.
I'm going to say, please choose the car seat that your providers will use correctly every time. If that means that you go out and purchase a off-the-shelf convertible car seat that goes from rear-facing to forward-facing, has 2 belt pads, goes up to a harness limit of 65 pounds, I could go on. And your providers are trained in how to use that correctly, then that's the one you should get. If your providers are familiar with a product like the PDM8 or the Quantum ACR, then use that. Whatever your service is going to practice on, know how to use, and know how to harness the child in correctly every time. That's the one I suggest you buy.
It might not be a bad idea, Catherine, to link or provide a hyperlink from this slide or the last slide to our videos on child.
Thank you, Chad. That's perfect because we do have 2 safe transport videos that Chad worked on with us, where we go over some of the basic criteria, the guidelines from the 2012 best practice the SEMSA release. And also I can provide on this slide set the product comparison sheet that we developed in that same safe transport committee, as well as the guidelines for people to reference. And
Thank
just
you.
so that you know, Chad, you answered the question, that first question you answered it. So thank you.
Oh, all right on. Thank you.